Good evening. I'm Karen Swartz, the director of the Adolescent Depression Awareness Program, and I'm so glad that you're joining us this evening for the second in a series of webinars we're doing related to adolescent depression. This evening, I'm going to be talking about adolescent depression and substance use. I want to make a general comment before we start. These are complex issues, and I am not trying to make particular comments about any individual situation. As you can imagine, that would be impossible. But I do want to talk about these issues generally and to point out some of the things that I think we all need to be aware of as we're trying to support young people in both of these issues. So what I'm going to discuss this evening, first is the relationship between psychiatric illness and substance use. It's complex, as I'll talk about in a few moments. I also want to do a little review about what depression looks like and what bipolar disorder looks like in teens, so that you have an opportunity to understand what those might be. It's an issue that teenagers often don't share their internal experiences, and there's no way to know just from looking at someone if they're actually going through these things. I'll share a little bit about the rates of psychiatric illness and substance use among adolescents and some of the issues we need to consider when we're thinking about substance use, especially in adolescents. I'll mention a little bit about treatment at the end, and then we'll have time for questions and hopefully good answers. So if we look at just how common mental health issues are for teens, this is information from the National Institute of Mental Health. Their estimate is that about 20% of 13 to 18-year-olds have some sort of serious mental health condition. So that's 1 in 5. About 11% have a mood disorder. About 10% have some sort of behavioral disorder, and 8% have an anxiety disorder. So 1 in 5 children between the ages of 13 and 18 will have a serious mental illness. The vast majority of those will not be recognized. If you look, on average, there is a delay of 8 to 10 years between symptoms starting and having them actually recognized. And there are a lot of reasons for this. Probably one of the most important is that young people don't know what they're going through, and they don't even know to mention it. The other, as I think you'll see when I'm talking about the symptoms, is that none of these are things like a broken leg. You can see if someone can't walk. You can see if someone's body is covered with a rash. You can tell if they have a fever. These are very private kinds of symptoms. And so often people can't even appreciate that their child is going through it. And so you have an illness that people don't know about, and the feelings are not that different than the kind of feelings you might have as a part of a stressful time in life or a period that you're super excited. And so often young people will decide that there's nothing wrong, they're just having a really intense experience. Now, 50% of mental illness begins by age 14 and 75% by age 24. So typically, depression, bipolar disorder, substance use, eating disorders, many of these conditions will begin when people are young. But as I said, on average, there's a long delay between having it start and actually being connected to treatment. Because of that, a large number of students, 37% of students that have a mental health condition, will drop out of school. If you look among those who drop out of school, the largest disability group comes from those with mental health issues. And if you look in the juvenile justice system, there's an enormously high percentage of those there who have some sort of mental illness. As I describe it, you can imagine that you could get caught up and addicted to substances, leading to trouble with the law, or might have very impaired judgment, particularly with bipolar disorder, that could also get you into trouble. I mentioned earlier that a lot of people don't get treatment. 60% of adults don't get the treatment they need, and 50% of youth don't receive the treatment they need. And so we have a major crisis in that we have many, many people who are not actually able to connect to services. As I said, sometimes because they don't know they need it, but other times because they don't want to do it. And we have another crisis, which is not having services readily available enough. So let me take a moment just to describe what depression looks like in teens. Again, what it looks like might look like nothing, in that many teenagers who are depressed will have teachers, parents, family, friends say, I didn't know that he was going through that. I didn't know she was going through that. Because as you'll see as I'm describing this, many of these are very personal or private kind of experiences. So depression symptoms fall into three broad categories. Changes in mood, those are the first two bullets. Physical changes, the next group, and then changes about how you feel about yourself. Those are the last two bullets. So let's start with mood change. Most people, when they think about depression, think about someone looking sad or down or maybe being tearful. The vast majority of those who have depression do not feel sad. Most of them feel either irritable or describe feeling nothing, sort of a lack of feeling. If you look at teens, the vast majority of teens going through depression will have an irritable mood rather than a sad or low mood. The other element of mood change is losing your ability to get excited about things, being able to have pleasure in activities. The medical term for that is anhedonia. So you have someone who is having many more negative feelings and then loses the capacity for positive feelings. And so in general, that ends up being a really negative situation for someone. Now, the physical things are all the things that are on a checklist in the doctor's office about sleep, appetite, energy. So appetite and weight will typically go either down or up. As you can imagine, appetite going down, weight goes down, appetite going up, weight goes up. The vast majority of teens going through depression will describe a decrease in appetite and a decrease in weight, because things don't taste good. They don't taste good, and you're just not interested in food. A few people will also comfort eat, and that they'll say the only thing I can enjoy or find pleasure in is actually food. And so they'll do that. But let me assure you, for most people, comfort eating does not involve carrots and salad. It involves pie and French fries. And so those individuals will have an increase in their weight. As far as sleep, the usual pattern is to have both difficulty falling asleep and then what we call early morning awakening, or having periods where you wake up throughout the night. Some people will sleep more, but the more typical experience is, as I described, having trouble getting to sleep, waking up through the night, and not feeling rested in the morning. But imagine what it's like. You wake up in the middle of the night, and it's not that you wake up to use the restroom and then go back to sleep. You wake up in the middle of the night, and then you have these negative thoughts that are spinning in your mind. So it can feel very lonely. Another symptom, which is very relevant to tonight's topic, is this bizarre combination of feeling both restless and wired and slowed down. So the vast majority of people most of the time feel fatigued or a lack of energy with depression, but it can be punctuated by these moments of feeling sort of tense and wired and anxious. And in those moments, substances, alcohol, marijuana, other substances are very appealing because they will help someone feel better for a short period of time. Now, I'm going to talk at length about the concern, which is that they also can interrupt other treatments. They get in the way of other treatments working or being effective. But in the short term, when you're feeling lousy, if there's something that can change how you feel, even if it's for a half an hour, you can imagine how appealing that is and how people can get in the pattern of using substances. Now, as far as concentration, that shows up in your work. So students find that they can't focus, they can't get work done in the same way. People that are working from home find that they can't multitask or get organized. And usually for students, they'll also say they're just slowed down. I can't think. I feel like I can't put thoughts together. I can't make decisions. I've had student athletes tell me that, when they're in Maryland, lacrosse is a big sport. I don't know anything about lacrosse, but they've taught me that you have to make a lot of decisions as you're going down the field. Should I keep the ball? Should I pass it, et cetera? And young people playing lacrosse have said, when I'm depressed, I can't decide anything. I can't see the whole field. I can't decide. So you're just slowing everything down. The last two symptoms are what affect your self-attitude, how you feel about yourself, your sense of self-worth. Now, obviously, these are the most painful and most serious symptoms. So people start feeling guilty. They don't feel like they're a good person. And you can imagine that it doesn't take much to go from, I'm not sure I'm contributing, I'm not sure I'm really a good friend or daughter or son or family member or anything. So maybe it'd be better if I'm not alive. And obviously, the most painful and tragic outcome of depression would be if someone has thoughts of suicide and takes his or her own life. So when we're trying to decide, does someone have the medical problem depression, we're looking for a group of these symptoms to come together and stay, where they're coming together, where you'll have at least 5 of these symptoms present for at least 2 weeks. Now, I've never in my entire career met someone who knew to get help in 2 weeks. As I said, the usual delay can be a decade. And often when people are younger, they attribute things like, well, I'm a teenager, things are hard, I don't expect it to be easy. And even as a young adult. So when people are going through this, again, think about what I just talked about. How you feel is very private. Whether you're enjoying things is private. Your sleep is private. How well your mind is working is private. And so we can't necessarily observe any of these in someone, which makes it really challenging if they don't know to tell us or they don't know about these symptoms so they can share them. So it's looking for a group of symptoms to come together and stay. Obviously, we're looking at symptoms that are causing some kind of clinical problem or we wouldn't make a diagnosis. And this is relevant for tonight's topic. We don't make the diagnosis if someone is intoxicated or in withdrawal. Now, in Baltimore City, where I work at Johns Hopkins, there is a major issue, unfortunately, with crack cocaine, and crack cocaine withdrawal can look just like major depression for a day or two. And then when someone's through it, they might have an underlying depression or not. But we wait to make sure that someone is not actively intoxicated or withdrawing. Now, when I started my residency in 1991 here at Johns Hopkins, we had a very, I think, backward idea about this, where you had to be clean and sober for 6 months before you could make a diagnosis officially of depression. Now, I'm happy to say we never thought of it that way because there's so many people, old and young, that are using substances as a way to try to manage or deal with the kind of mood symptoms they're having, that, you know, that was later understood to be not very helpful, because mood disorders and substance use problems go together very commonly. Now, major depression is just having low moods. I'm going to talk about mania and bipolar disorder in a moment, but major depression is just having low moods. Now, for mania, which is the upside of bipolar disorder, bipolar, 2 poles, where you have both the low moods I've just described, but also these very high moods, is a different form of a mood disorder. So here again, you have change in mood, but instead of being low, it is over the top. Someone has an elevated mood, they're expansive, or sometimes they're extremely irritable. Often people have inflated self-esteem or even grandiosity, which is having false ideas that you're very famous or that you have a brilliant idea that's going to make you $1 million, or in very extreme circumstances that perhaps you've been given a special mission to perform. Now, those are how you feel. So the feelings are over the top in a positive way until it gets really out of control. And then people often describe that it gets scary. But the physical things that go with mania are cranking up the volume, right? So there's no need for sleep. People are talking in a very pressured way. You can't get a word in edgewise because they have so many thoughts. Someone will say, I have so many thoughts, I can't even keep up with them. People aren't able to finish tasks because they get caught up in the next thing to do. And they're often very physically active, doing lots of activities, not able to sit still, moving. And then as it relates sometimes to substances and substance use, absolutely not worrying about consequences. So much more likely to take risks, much more likely to do potentially dangerous things and not think that there could be any bad consequences because there's so much confidence. Manic depressive illness, bipolar 1, they're the same thing. As I said, involves the low moods and the high moods. Here we're looking for at least three symptoms lasting for 1 week. Now that's shorter than major depression. In general, the depressive episodes will go on for months if untreated, whereas the manic episodes will go on for weeks or even might last just a day or two. And so in general, the manic periods are much, much shorter. And some people even have a form of rapid cycling where they just have breakthrough symptoms. What's much more common at the beginning of having these symptoms is that the symptoms come and go so quickly that the individual having them doesn't even know if they had them. It's like, I don't know, what was that? And so over time, they last for longer periods of time. And so they're more evident to others. Bipolar disorder is much less common. It's, as I said, it's about 11% that say that by report say that they have mood symptoms when they're young. If you look at lifetime prevalence, it's about 20% of women, 10% of men that'll have a major depressive episode at some point, and it's 1% of the population that will have bipolar 1. And there the rates are the same for men and women. So with that background about mood, let's talk a little bit about mood and the other things that go along with it. None of these things are fair, but they're just factual. That if you have major depression, you're also at risk of having had or developing other conditions too. The common ones include, if you have ADD as a child, you're at higher risk for depression or bipolar disorder later. If you have an anxiety disorder, usually ADD and the anxiety disorders come at a younger age, and then depression follows later. If you have major depression, you're also at risk of having issues with substances and having issues with other kind of behavioral problems. Some of the behavioral problems that we see in addition to substances are things like eating disorders, cutting, those kinds of issues where you're trying to feel different. So if we look at the way that depression and other psychiatric illness relates to substance use, one thing I want to say importantly is that sometimes they're not related, and that many people will have depression and never have issues with substance. Other individuals have issues with substances and never develop depression. It's not automatic that they go together. But sometimes you're trying to figure out, well, how do they relate? For some people, because they have depression, they will turn to substances to try to feel better. I see a lot of that. Young people who clearly had depression or anxiety before, but when they use the substances, they got more from them. You know, obviously people use these substances because they feel differently. They are something that can be potentially addictive because they give people very positive experiences or positive feelings. If you're depressed and you get relief from your depression, plus you get whatever benefit anyone else lucky enough not to have depression would have with alcohol or marijuana or other drugs, you'd say, oh, okay, I get that. I want to feel differently. For others, it's the opposite. They're using substances, and because they're using substances, they will develop depression. There are probably ways that the substances potentially change the brain that would put someone at risk of developing depression. The way it usually goes, though, is that there are both of these interacting in a very complex way, and how they're really interacting is in a way that they're reinforcing. Because I'm depressed, I've been using substances. Because I'm using substances, that might be either worsening my depression or making it trickier to treat my depression. And so there's this reinforcing cycle for many individuals that have the challenge of these two conditions. So as I mentioned, there are other behaviors we commonly see with mood disorders in adolescents, including eating disorders, alcohol, other substances, and then cutting. And by cutting, I mean superficial cutting, where someone is not trying to end their life, but they'll superficially cut. And if you talk to young people doing this, what they will describe is that their motivation is to change how they feel. So in that way, it's very different than what people will say about when they're drinking alcohol or smoking marijuana or doing any of these things, that it changes how they feel for a short period of time because it is such an intense experience. So behaviors and moods. So by behaviors, I'm going to use that broadly to mean substances and eating disorders and cutting. These behaviors absolutely alter moods for brief periods. That's where their power comes from. And the behaviors can also destabilize moods. So generally, if people are doing this regularly, it has a destabilizing effect on mood. But they can absolutely occur independently. It's not that everyone using substances, the reality is that the number of teenagers that at least experiment or try substances is enormous. And most of them are lucky enough to never have a mood disorder or ever develop a mood disorder. However, if you're having difficulty with both, you need to get both under control. For example, it's nearly impossible to have a really good outcome for treating depression if someone is continuing to smoke marijuana, drink alcohol, cut, engage in eating disorder behaviors. This really struck me. I read this a couple years ago in the Baltimore Sun with a young woman describing what smoking marijuana for the first time was like. She was 13 at the time. So my immediate reaction was that I'm going to do this again. I felt as if I could enjoy myself more. I didn't have to deal with any of the problems around me. I was just sort of in this safe space where I could relax for a moment and get away from the real world. Now, I don't know, because the article didn't describe whether this was a young woman also with the challenge of a mood or anxiety disorder, but you can imagine how appealing this is. And I want you to imagine how much more appealing it is if you do have anxiety or depression and you're feeling this way as a change or a relief from those other negative feelings. So what are the kinds of symptoms you can see with substance use broadly? And then I'm going to talk about some individual substances in more detail. Well, people withdraw from their family and friends. There can be behavioral changes. People will keep using the substances even if it's dangerous. They're using at a degree that's dangerous, or they're doing risky things, for example, driving when intoxicated. They're more likely to engage in risky behaviors because when you're intoxicated, you don't have that ability to filter or say, should I do this? Should I not do this? Some people really lose control and they're using at a level that is problematic. They're not able to fulfill their responsibilities. They're using to a degree that they're not able to support it financially, or they'll do things that are uncharacteristic. For example, someone who's using so frequently that they now are caught up in really uncharacteristic behaviors like stealing or doing other things to be able to afford it. What also happens with ongoing use is that you can develop tolerance. By tolerance, the classic thing is that I used to be able to drink 2 beers and feel a buzz, and now it takes 6. Your body becomes used to something, and so you need to escalate the amount you're using. When you develop tolerance, your body's also used to having it. So if you skip it and you're not using, you'll have withdrawal and your body will feel that it's not there. So it's this terrible reinforcing pattern. I think many know that heroin particularly, there's terrible withdrawal. And so some people will say, I'm not even feeling a high anymore. I just can't tolerate how it feels if I don't use. And then people will often get into this trap where they feel like they can't function if they don't have that substance. So dual diagnosis is the term we use for having both together, having a mood or anxiety or other psychiatric problem in addition to substance use. So about a third who have mental illness also have substance abuse, and about a third with alcohol abuse have a mental illness. That's one of the most common forms of substance use. And about 50% or more of those using other substances have mental illness. Alcohol is just so broadly used that it's a lower percentage. So higher risk of dual diagnosis, men are at higher risk, those with socioeconomic challenges, those who have served in the military, and those who have other medical problems. And as I'll talk about with the opiate pain medicines, people often have opioid addictions because they have had a pain condition or other medical problem where they've been prescribed some sort of opiate pain medicine, which is a setup for becoming addicted. So I have this family liquor cabinet here for a reason. I think probably most teenagers probably in the world, and certainly in the United States, could find beer or other kind of liquor if they were trying. There are some facts about alcohol. 4,500 under the age of 21 die due to alcohol-related car crashes, homicides, suicides, or alcohol poisoning. Alcohol withdrawal actually can be fatal. It's incredibly dangerous. And actually that withdrawal rate can be more dangerous than heroin withdrawal. And they did a survey of teens in Maryland, and they had over 100,000 that reported having engaged in binge drinking during the past month. And there are big issues coming up where adults serving minors are now being held legally accountable if things happen because of, their behavior when they leave a party or something of that sort. So I think, even though, again, I want to be clear about this. I'm not being judgmental. I don't think it's realistic to think that we'll just simply have no teenagers experiment with any of these substances. I'm a psychiatrist that takes care of individuals with mood disorders. And so the problems worry me, but they worry me even more for the young people who have depression and bipolar disorder because they're vulnerable in a different way. Other substances that are quite easily accessed are the pain medicines. This is the phenomenon that happened with the misused prescription opioids. So these are things like oxycodone, OxyContin, Vicodin, Dilaudid, what the dentist might give someone's grandmother after the extraction, or what you have after your hip surgery. And too many of us just pop them in the medicine cabinet and keep them there versus routinely cleaning that out and taking back to the pharmacy or dropping off. Many police stations have a place you can safely drop off medicines in, lock boxes. And so you can say, okay, I don't need to have all that there, because when you look to say, okay, where did people get these pills, right? This is an exploding problem. So the vast majority of them, in a survey done by NIDA, was that, 5.7 million of them, when they're saying, how did you get it? Well, I got it from free from a friend or a relative, or a single doctor gave it to me, presumably to treat pain, or I bought it from a friend, or I took it. Many teenagers will describe to me that they went and checked out what was in their grandparents' medicine cabinet, assuming they wouldn't notice if it had disappeared. And then you get into it where you start buying them from a drug dealer, a stranger, or that you do what we call doctor shopping, where you go to multiple different people hoping that you'll be able to get a larger number. There's an issue though, because pain pills, either with a prescription or from the street, are actually quite expensive. So that ends up being problematic. So let me take a few moments to talk about marijuana. And again, I want to be clear. There are clearly reasons that people should use medical marijuana. I'm not making statements about that. I'm not trying to make some broad statement that no one, that there aren't medical uses for marijuana. And I'm not making a political statement. I'm a psychiatrist talking about the fact that marijuana mixing with the mood anxiety disorder can be really problematic. So I'm making the comments from that way, not to try to make a broader statement. So here are some facts. It's the second most commonly used substance after alcohol in the United States. Many, many, many millions and millions of young adults are using marijuana every year. And in general, young people feel that it's very low risk. Now, I would argue that they also think alcohol is very low risk, and alcohol is not low risk, and marijuana is not low risk. It's low risk for some people and high risk for others. The problem is we often do not know which group people are in. So what happens when people get high? Well, you heard, in that quote from that young woman, people have this intense experience that they find exciting. They feel like they have altered senses. They can see things more in brighter colors. They have some change in how they experience time. Many people describe feeling mellow. The people that feel paranoid or odd or scared don't keep doing it. People do it because they like typically how they feel. Now, they will also say, well, no, when I'm high or when I'm stoned, I can't, you don't want me deciding anything or having problem solving kind of challenges, but that's okay because I do it to have a break from how I'm feeling. And I anticipate that that'll go away. There are some real health effects for marijuana, and these are primarily from smoking because of what happens with the lungs, right? There's growing evidence that, like cigarettes, there can be long-term breathing problems. There are clearly changes in heart rate. I'll show you something about smoke versus vape marijuana in a moment. And there can be difficulties with child development during and after pregnancy. Some people report having hallucinations. So that's seeing or hearing or smelling, tasting, feeling something that's not there. Temporarily feeling paranoid. And if you do have another illness like schizophrenia, bipolar disorder, it can make the symptoms more intense or worsen them. And there's growing evidence that it can potentially, maybe not worsen, but interfere with the treatment of other mood disorders and anxiety disorders. Now, this is an interesting survey that was done on about 270 people in the United Kingdom. 2/3 of them were young adults, so under 24. And they were asked to rate how harmful they found different substances. Now, in the United Kingdom, Class A, the bright pinks, are illegal and have the harshest penalties. The turquoise are Class B. So again, they're not legal, but they have much reduced penalties. And then the gray bars are legal. So that would be alcohol and tobacco. And, you know, putting marijuana in sort of a category of it's state by state, it's similar. What's interesting is that in this survey, marijuana, cannabis, was thought to be less dangerous than alcohol. And one could argue for individual people it may be, but the thought of we have to be careful, we want to be thoughtful about it, I think we have to realize that most teens are going to think this is not something that would be risky. One of the reasons that I think psychiatrists, and certainly I am more worried about marijuana over time, is that there has been a pattern of the marijuana having increasingly high THC content, so the active ingredient. So if you look from 1995 through 2014, this was a study that looked at how potent was the marijuana that was seized by the DEA when they were doing, you know, drug raids and making arrests. And you can see that the potency of the marijuana has dramatically gone up during that 20-year period. And the percent that has this very high count, very high potency marijuana is dramatically higher during that time period. And so the actual potency is different than, say, in the 60s or 70s and what was typically available on the street. Now, medical cannabis changes this in both some are less potent and some are more potent. And again, I'm not trying to make any statement about medical cannabis in that I'm sure it is very, very helpful for people with very particular conditions. But in the same way that alcohol being nearly universally available because, you know, many people have beer in the fridge or alcohol in their home to serve guests, because more individuals are getting medical cannabis and it's more broadly available, that means that it's just more broadly available. So teens can find it or get it. And, you know, that again, I'm not being judgmental at all. I'm simply saying we have to look at the fact that this is going to be more of an issue. If you look to see where cannabis is legal, you can see that the number of states, the green would be it's approved for recreational use, blue is medical use. So the vast majority of states in the United States now have either recreational or medical legal marijuana available. Now, I want to mention something about vaping, just because young people will say, or maybe try to convince their parents that vaping isn't that dangerous. What's interesting is that vaping actually is a way, if you use the same amount of THC, if you compare smoking here where there are 0 milligrams in the light blue, 10 milligrams in the orange, and then 25 milligrams in the gray, with the same amount active ingredient, vaping gets a higher percent effect in the body. And it also gets a higher change in heart rate in the body. So this is increase in heart rate, where again, those who are vaping have more of a heart rate change than those who are smoking. They did a survey with teens and they said among teens who had used an e-cigarette, 28% had used that e-cigarette to vape. And so that's, I think we have to assume that this is a pretty common behavior that's going on now among teens, especially those who have an e-cigarette or vaping potential. And here's just one study that I think has been thoughtfully done. This is a subset of a big study done in Europe called the Emblem study. And they have been following almost 2,000 individuals who have bipolar disorder prospectively for 2 years. And they were comparing how well individuals did in getting better based on whether they had never used cannabis, that's the blue bars. If they had previously used, so they were using, but then they stopped, those would be the red bars, or if they were still using, the green. Now, this goes in order of how well someone is. So recovery is they've gotten well, their symptoms are under control, they're functioning. Remission is symptoms are much better, maybe not where you'd like to be, but much better. Recurrence is you were well, but the symptoms came back. And relapse is that you never quite got well and now you're having much more serious symptoms. So different degrees. And it's not very subtle. If the outcome we all would like for someone to be in recovery, the smallest percent is among those who are currently using. So if you look at those who achieve recovery, most of them never used or had stopped using. And if you look at those who are having difficulty, that's a high percent who are currently using. So for people to get well, and I can tell you clinically, that's been my experience. Occasionally it's not the case, but most of the time people will have much better response to treatment if they're able to stop drinking, stop using substances, stop cutting, stop engaging in eating disorder behavior, that eliminating those behaviors that are understandable. You know why people do them. They're just trying to feel better, but they get in the way of really responding to treatment. So there are safety concerns, right? I mentioned that the potency of the marijuana that's available is going up. And also you've heard this in the news, heroin is now being cut with fentanyl. And so something incredibly dangerous and even more, it's hard to imagine something more addictive than heroin, is mixed in with the heroin. I want to mention something about that because most people say heroin. We have high school kids in the counties surrounding the city who are quite addicted to heroin. And how does that happen? Well, because someone might start by getting pain pills out of a medicine cabinet or from a friend. They become addicted to the pain pills and then they can't afford the pain pills. But tragically, heroin's quite cheap. And so if you're addicted to alcohol, you're twice as likely to become addicted to heroin, marijuana 3 times, cocaine 15 times. But if you're addicted to those opiate pain pills, you are 40 times more likely than if you're not to get addicted to heroin. And so this is sort of a tragic thing that is a reason that this is really a crisis that we need to address more actively. It's also that these are very dangerous medicines where people are not trying to overdose, but they are dying from opioid-related overdoses, partly because now the heroin and other opiates they're getting might be cut with fentanyl, which is so powerful that you're at high risk of dying. So the vast majority of the drug and alcohol related deaths in Maryland are related to opioid overdoses. And so this has doubled since 2010. So this is a real public health crisis. I mentioned this earlier, and the next webinar we're going to be doing in May is going to actually focus on treatment broadly for mood disorders, but also treatment of the associated conditions that we commonly see for those who have the challenge of depression or bipolar disorder. And treatment involves treatment of both, right? So it's actively treating the depression, the bipolar disorder, the anxiety, whatever the psychiatric condition is, but then also treating the substances. And in general, people have to have an opportunity to be detoxified, and then they need some sort of intensive support that's usually most effective in groups. So some people find that AA is terrific, Alcoholics Anonymous. Others find that going to an intensive program, either inpatient or outpatient, is something that they need. It's obviously very individual. It's a rare person that can simply decide to stop. That's admirable, but I don't think we want to have that expectation because so few people are able to do that. Now, with the drug overdoses, a good thing is happening in that Narcan, naloxone, which is a medicine that can reverse the effects of opiates, especially if you've had an overdose, is now being stocked in many school health suites, and it's available as a prescription. So if someone's had a problem with opiate addiction and they've, for example, been treated in the hospital, they often leave the hospital or leave an outpatient appointment with the prescription for Narcan, so they have it available as a backup. So before we get into questions, I just want to make a couple concluding points. Psychiatric illnesses are unfortunately quite common among teens, but they are usually not recognized. And they're not recognized for all the reasons I said. The symptoms are intensely personal and they're private, and you can't necessarily see them. Substance use, sometimes people can tell what's going on, sometimes they can't, but they're both common and they may come together. Because my focus is treating teenagers and adults who have mood disorders, I see many where the substance use is an attempt to self-medicate. Now, I have self-medicate on this slide in quotes because, of course, it's not effective. You know, you would think if you're self-medicating, it's that you're actually doing something that's going to help. And it sometimes just perpetuates and it makes it harder for other treatments to be effective. Because of these more potent drugs available, I think that we need to worry that the risk to young people is greater than it was maybe 10 or 20 years ago. But I want to end on a very positive message before we go to treat the questions, which is that these are both treatable conditions, psychiatric illnesses and substance disorders. And so if you're concerned, what to do? Well, talk to your child about your concern. If you're a teacher, talk to the counselors at the school about your concern about someone. Put your heads together, talk about how you might approach the parents. Think about getting an evaluation and get more information. It's amazing what the other adults that are part of your child's life, the information they have, be the school counselor, the coaches, the activity leaders, they spend a lot of time with. And then I just want to make a point about the website. Most of you went there to sign up, but you might not know that the ADAP Education website has a source of information. This is our homepage, and on that you'll see that there's ADAP for parents and students, so lots of information and different things that you can learn. There's also the webinar section where you can find out about our future webinars. And with that, I'd be very happy to take questions. So if people would like to put them in the question and answer or in the chat, I will look at both of those. Now, I will say that most teenagers, if you bring up these issues, will absolutely positively discount it because they're not going to believe you. And it's also a part of depression, unfortunately, to not think that it's a treatable illness. You just think it's part of who you are. And one reason for that is that it is a slow worsening. If people went from feeling fine to feeling terrible, they'd recognize it. But almost no one has that experience. The experience people have is they feel okay, and then a little less okay, and a little less okay, and then it's over time things actually worsen. And so then it's really tricky. Okay, so a couple different questions have come up. One is, what can be done about treatment-resistant depression? So that's a great question. With treatment-resistant depression, it's often a good idea to get a second opinion, to get fresh eyes, and someone perhaps at an academic center. A lot of mood disorder centers have places where you can get consultations and expert opinions. There's a national network of depression centers that has that available, and there's information all over the country about places that you can actually get second opinions. What I can tell you is that here are some of the challenges of treating depression. We don't have the kind of lab test that can guide us the way you would if you were treating, say, a urinary tract infection. With a urinary tract infection, you could send a sample to the lab and then say, oh, you're on the right antibiotic or you're not. With treating depression, a couple big challenges. One, you have to have a little trial and error because we don't know how to do that. And then two, it can take 4 to 6 weeks on a full dose of an antidepressant to be able to actually see improvement or feel improvement, more importantly. Very few people believe that medicines can take 4 to 6 weeks to work. Their response is, are you kidding me? Medicine should work in a day or two, right? Especially young people. If you are a young person, you expect, what medicines have you had? You've had antibiotics and pain medicine. So you don't expect medicines to take a long time to work. So what I would suggest for that, because with treatment-resistant depression, there are a lot of treatment strategies, but it often involves tailoring something and doing combinations and not simply saying, oh, we tried antidepressant 1, we'll now try antidepressant 2. So great question about what's the first step in evaluating my child? Do I see their doctor or go straight to a therapist? I have found that many people find that talking to their primary care doctor or the pediatrician is a great first place to start for a couple reasons. Especially if that physician knows your child, they might be able to give you some insight and are often very comfortable having an initial conversation. They then often know people that are in your network or people in the community that they've worked with. And because they know your child, they might be able to do a good match of, a therapist, here's someone that I know works well with young men that have these interests or young women who have these interests. And so that might be a good match. If you're convinced that there is something going on psychiatric, then you might start with a mental health professional, and that would be fine. But starting with the pediatrician is often a great first step. Okay, other questions. Can you have bipolar disorder and not have any noticeable manic episodes? Absolutely, for a couple reasons. One is some people put enormous energy into controlling their symptoms and not letting people see how they feel. And so it is quite possible that someone is having all kinds of internal experiences and you had no idea. Now, usually if people have the most severe forms and the most dramatic symptoms, obviously others would notice, but that is usually not how it starts when people are young. And so I've absolutely seen people that I'm talking to them, I'm asking very particular questions as a psychiatrist, and they're being honest and say, oh, I've had that. And yeah, my mind races and I got these ideas. And I'll say, well, did you tell anyone? I said, well, no, I wasn't going to tell anyone. I didn't even know what it was. And it sort of freaked me out that I was going through this. And so they'll keep it very private. And the keeping it very private is obviously a big challenge because then others don't know. And I think that's really hard. And I think it's really hard for parents. So there's a good question. If a lot of people diagnosed with bipolar disorder also rely on marijuana, are there any adverse effects on that substance abuse with their medication? Again, I can't say for every single person, but my experience clinically is that the medications are much more effective if someone is not using substances. That means not drinking, not smoking. I understand why people do it. They're saying, look, I can feel better in an hour and you're telling me your treatment's going to take a couple weeks. I think I'll stick with my plan. I understand that. The problem is that there does seem to be a pattern where the effectiveness of the other treatments is just much less if someone's continuing to drink and continuing to use other substances. So a question about brain mapping, we don't currently, whether that could help guide treatment. Right now, we don't have any brain imaging that reliably can help us in treatment. I think that'll be exciting. I think there are brilliant people that are working on that because that would be fantastic, wouldn't it? If you could have a brain scan or a blood test or something to say, okay, it's just like saying you need to be on this antibiotic and not that one. We're not there yet, but I do think that as we have a growing understanding of the brain, that we'll be in a much better place to be able to use some of those technologies to help us. So the question about whether these things are hereditary, they are and they're not. And what I mean by that is depression, bipolar disorder, they run in some families, but there are also individuals that no one else in the family has it. And that's the same for many medical conditions. in general, if you say, do they have the potential of being hereditary? Yes, they do, both depression and bipolar disorder and substance use. But there's certainly individuals where they're the only person in their family that has it. Why that happens sometimes and other times it doesn't, we really don't understand yet. Here's another question. Based on the early evidence, has the pandemic impacted the issue? Absolutely. So there are a couple ways it's impacted. There was a recent study that looked not at teenagers, but young adults. So let's include them. And what they found, if you looked, when they were asking about depression, anxiety, substance use, and suicidal thoughts, young adults had the most dramatic increase in depressive symptoms, anxiety symptoms, escalating substance use, and suicidal thoughts compared to older individuals. So if you look through it, highest rates of those things changed in the pandemic for the youngest age group, and then it went down, 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 and then older individuals in their 70s, 80s had the lowest rates. And so this pandemic, and you think about that, well, why has it been so hard on the young adults? Well, they're supposed to be doing certain things developmentally, right? They're supposed to be getting on with their life, going to college, getting the first jobs, traveling, having these adventures. And I think it's really hit them very hard, all the limitations. And they also just aren't established so that they've gone through other things. You know, my older sister who works in New York City had a really important point. She said, you know, those of us who were here when 9/11 happened seem to be handling this different and better than our younger colleagues that never went through that. You know, I do think we all get coping skills and resilience as we age. And so the younger teenagers and young adults, college age students, people just starting their careers, that's a group I particularly worry about. And so, yes, we have growing evidence that that's a group we really need to pay attention to. So a question about the ratio between girls versus boys with depression. So before puberty hits, it's the same, 1-to-1. The rate of depression in girls versus boys, once young women start getting their periods and go through puberty, is 2-to-1. And that continues with women having twice the rate of men through menopause. So we think that's because there are forms of depression both men and women get. And then women have the added challenge of some hormonally triggered periods of depression. So the question about if a teenager has anxiety or depression, how likely is it that those issues will persist into adulthood, or will they get worse? That's highly individual. You know, the patterns of these symptoms are highly individual too, and that some people have periods of really severe symptoms, and then they have long periods of time that they don't have them. For some, it's very episodic. For others, they have a lingering amount all the time. So that's so individual, it's hard to answer. But there's the potential that without treatment, they can get worse. And so, you know, my bias is to have someone understand what they're going through, or also that, you know, if they get treated earlier, that sometimes that they just aren't suffering as much, which is important. Can I talk about tobacco use to self-medicate? Okay, absolutely. And I was remiss not to mention this earlier. If you look among those who have psychiatric problems of different sorts, high rates of tobacco use. What patients have described to me is that when they smoke, they feel calmer and more alert. That's an incredibly powerful experience, calmer and more alert at the same time. What I can tell you is I've worked with many people who had worked hard to give up smoking for all the positive health reasons to give up smoking. And then their depression came back. And as their depression came back, they picked up smoking again because it helped them feel better. So again, there was data from a study done a number of years ago at the National Institute of Drug Abuse that cigarette smoke had some monoamine oxidase inhibitory properties. And I bring that up because one class of antidepressants are monoamine oxidase inhibitors. So there is something about cigarette smoke that does seem to have short-term benefit. Now, of course, you're balancing that with all the remarkably high risk of lung cancer, cardiac disease, vascular disease. So if you look at it, it's terrible, but in the short run, as powerful as any of the other things I've talked about tonight in changing how you feel in the short term. Okay, we have just a minute or two, so I'm just taking a look at these other questions. So a question that I feel positive about: what are your recommendations for discussing these issues within the classroom setting for teens to be more knowledgeable and share experiences in a safe space? Well, that feels like a setup. At Hopkins, we've developed a program, the Adolescent Depression Awareness Program, that probably many of you are aware of, but maybe not everyone, which is a curriculum to talk about depression and bipolar disorder. And I know almost every school curriculum in middle school and high school has opportunities, typically in health class or something that's like a health class, to talk about the substance issues. And so I think there are opportunities. What's challenging is that not everyone has the same level of comfort, of course, in talking in that setting. Not everyone has the same level of comfort of talking with families. And so I think as many different opportunities as possible that we can set up, then that just gives someone, you never know when they're going to be ready to talk about something. If there are any schools that you're affiliated with that would be interested in learning about ADAP, please send them to the website. It's easy to get in touch with us, and we're happy to talk to the schools about how they can get the school professionals trained to bring the program. At this point, we have the ability to train anyone with our web-based training that would want to be trained in the United States. It's a curriculum for high school students, and we're happy to share it with anyone. So top actions on how to prevent depression in teens. I wish I knew that. There are certain health behaviors that aren't enough, but we should all be doing and do seem to have some positive action for teens. Enough sleep. Boy, right now in the pandemic, we could all use that, right? So enough sleep, not using substances, having a regular schedule, having an opportunity to talk about these issues, being open if they come up. And I think, look, the thing that I battle every day is that there is still terrible stigma about depression and bipolar disorder. People do not want to have these diagnoses. I take care of a number of doctors who know better medically. They don't want to have this diagnosis. This is one that it's no different a medical problem than having diabetes or hypertension or anything else. That's the way I see it. It's a brain disease that we can treat. That is not the way it's viewed in our society. There is no way that that's the way it's viewed in our society. And so what worries me is that we just need to be more open and say as many different ways as we can, this is not a reflection on you. But here's the problem. Depression takes away your confidence. It makes people feel negatively about themselves. And so they are much less likely to share how they're feeling, because the illness itself has gotten them to feel like, oh, I'm just being lazy. I'm just screwing up. I'm just all these other things. It's inaccurate, but it's such a powerful experience that it keeps people quiet. Now, with that, I want to thank all of you for your participation, for these terrific questions. We're at 8 o'clock, so I'm going to thank you for your participation, and we're going to conclude the webinar. Thanks very much.